Good afternoon, everybody. I'm going to be showing you already one slide to engage you here. It's a Mentimeter, and if you could answer this question in a couple of words, what is the main advantage of online training? So we have a QR code, or you can also just enter the code number that you see right below the headline at mentimeter.com. I'm going to move forward to the slide so that we can see the results. Oh, can we switch to that other screen, please? Technical people, thank you. So as soon as some of you start entering answers, we will be seeing here what those are. Hopefully. Oh, they didn't get it. Okay, I'll go. Can we switch back to the original slide? I don't have control of that, unfortunately, because this is a website. Joe, do you remember? Oh, there it is. Thank you so much. In case you didn't catch that. Okay. Otherwise, the numbers, well, it's a long number. 15215939. Okay, let's try that again. Could we look at the Mentimeter results screen? Oh, it's not working? Oh, it is? Okay. Great, thank you. So we're seeing here already some answers that adaptability, time saving, no need to travel, one pace, cheaper, accessible, flexible, access, self-paced. These are all advantages that you see for online training. Well, thank you, everybody. So I didn't present myself. Sorry about that. I'm Manjari from PATH, and I'll be moderating this session. And we have our great speakers. Can we switch back to the presentation again? Thank you so much. So we have our speakers here who are going to share with us their experience in developing and then in the implementation of 3 different online training solutions. So Jhilmil Bahl from WHO, Elizabeth Kohlway from Sabin, Cecilia de Bustos from UNICEF, Vivian Salomon, also from UNICEF in Guatemala, and Sanjay Kapur from JSI in India. You can read a bit more about their bio, very experienced speakers in online training. So we're gonna do a modality in which I will be asking one question, and then each one of our speakers will be sharing with us an answer for their specific online training solution. And then at the end, we'll have some time for questions. So our first question to get us all introduced into what these online training solutions were about is what was the aim and approach for your online training? And we'll get started with Jhilmil, please.
Yes, good afternoon, everyone. So I'm here to talk about the COVID recovery fellowships. These were the fellowships that we co-designed with the Sabin Institute, Boost Community. Colleague Elizabeth is here into 2022. The aim of this fellowship was to build capacity at national and subnational level of immunization professionals to plan and implement activities for COVID-19 recovery and routine immunization strengthening in general. And the fellowships happened in two phases. The phase one included online live engagements where experts came in from different fields to talk about different aspects of routine immunization strengthening, COVID recovery, which led to each participant developing their own strategic plan or case study. And these plans were reviewed by experts, and each proposal received feedback. Then we moved on to the second phase, which involved mentoring. So selected candidates got assigned to mentors. We had 5 mentors for 30 fellows, and the mentor and mentees were meeting each other on a regular basis to track progress, problem solve, set goals. Then this was a very supportive kind of mentorship where it actually led to some case studies being developed, and in fact some were even published in scientific journals. And also there was some limited funding available for the people who needed it.
Thank you very much, Jhilmil. And same question about the AIMM approach for the UNICEF online training solution.
Thank you, Manjari. So we did an online training on how to engage or management of cold chain equipment for the Ministry of Health. Our main objective was to train as many health workers on the management of cold chain equipment to improve immunization and increase vaccine coverage. So one of the first things that we did with the Ministry of Health is sit down with them and to start like assessing the needs of what they had on cold chain. We first saw that the strengthening of cold chain management was needed. We started with an in-person training that actually PAHO was involved. Also, we had help from the Ministry of Health of Nicaragua and also from El Salvador. They went there to help us. But the in-person training, as many of you mentioned, it was like we needed a lot of funding, and it was during COVID-19, so the traveling was a restriction. So we did that first training. Then we did some regional ones, and that's when with the Ministry of Health, we decided it was like an online training needed for everybody to actually have the chance to get that. We did the online capacity building, and then after that, just like what we try to think with the Ministry of Health is that we needed to coordinate with as many stakeholders possible also, because a lot of people were there to trying to get into the cold chain management during COVID-19. So that's when we decided to just sit down, coordinate, and also include the Social Security, which in Guatemala is something that it's not particularly coordination all the time with the MOH. So we sat down with all those stakeholders, and at the end, we had an online training that it's sitting in the Ministry of Health server. They are the ones managing it, and they can change it as much as they want it, because for example, we're having a change of government next year, so they need if it were sitting with us at UNICEF or at any other stakeholder, we need to change everything. But that's something that they own. It's in their system, so they can change and adapt it as much as they want it. So that's something that at the end we had. So it was how we approach it, and thank you.
Thank you very much. And next one, Dr. Sanjay, if you could tell us about your online training approach.
Okay, let me take you to India. We have about 30 million pregnancies every year in India and 27 million newborns. So that's the kind of immunization cohort we have in India. And therefore, it is imperative that we have a very commensurate workforce to sort of train the vaccinators, retrain them again and again. Because of which India right now has about 250,000 vaccinators spread throughout the country. The challenge is again training, retraining them because of attrition and new entries. Some of the challenges which I have mentioned here are, for example, it takes a lot of time to saturate all the 250,000 health workers. If there are changes in guidelines, it's not very easy to sort of spread them at a short period of time. Refresher trainings are difficult. The quality of training can be very variable because till now India has been using instructor-led classroom trainings for the last several decades. There are large variations in the delivery processes. Logistics management is a major issue because we have, like 35 states and so many health workers to be trained. And also it is very difficult to track the trainees, where what they are doing, how they are doing, how the training has been, useful. So because of these challenges, GSI, about 3-4 years back, we made a capacity assessment of the health workers, and also we did an assessment of the preparedness of health workers to undergo any other type of training, including digital training, which is going beyond the classical classroom training. It was an assessment of the entire health system. We assessed whether they use mobile phones, they use apps or not, how comfortable they are, how much time they spend every day on the mobile phones, how frequently they would be using it, and their interest level. So based on that assessment, the results were very encouraging. And because we got a good result, the government of India requested GSI to develop what is called a learning management system. It has interactive e-learning modules. It has quizzes and games. There is a very important point is there is a real-time monitoring dashboard of all the trainees, which means that we are able to track individual trainee, and their supervisors know that the particular trainee is strong in which components of the immunization and would need further training in which other components of the training. Also, there is an instant e-certificate. So the moment you finish the training, you can get training certificate, whether it is gold or silver. So there's a healthy competition. So this is a learning management system which we have created for training of health workers. Thank you.
Thank you very much. And now our next question to our speakers is, what is one advantage of your online training approach compared to previous approaches? And we'll start with Elizabeth.
Thank you, and good afternoon, everyone. So I think there are really several advantages to the online approach that we took with the fellowship program, but I'll just highlight one, which was the audience of our fellowship, both in terms of our expanded reach and also the diverse composition of our fellows. So in terms of reach, we were able to engage with more than 1,000 participants on a weekly basis through our suite of online platforms, including Zoom, our Boost community online platform, and Telegram channels. And this wouldn't have been possible with an in-person training, especially considering the high cost of air travel, lodging, visa issues, etc. And if we had gone with an in-person training, we would have had to cap the size of the cohort. And as a result, we would have restricted important knowledge and skills and peer-to-peer exchanges that were really needed during this critical time of COVID-19 recovery. So moreover, the composition of our participants was quite diverse. Not only were we able to engage immunization professionals at the national level, but also those working at the subnational level, so from the province to the health facility level. And the subnational folks were greater than 50% of participants in the program. And this group doesn't always have access to global trainings, and usually programs kind of stop at the national level. So with just a secure internet connection, participants were able to access comprehensive presentations, engage with their peers and facilitators on an ongoing basis throughout the training. I will pause and just say that obviously having a secure internet connection is not a given. So we did try to do some workarounds, whether it was reducing the size of PDF of presentations, making sure that the recordings were downloadable. So trying to really find ways to meet our participants where they were. Thank you.
Thank you, Elizabeth. And then I'd like to ask Cecilia about the advantage of your approach.
Yeah, thank you very much. I think we are quite similar actually to the rest of our colleagues. First of all, in a context of a country where there are very limited resources, financial resources for any capacity strengthening activities, I think this gave us the opportunity to be able to really reach as many health workers as possible. So that made a really big difference because we felt, we assessed together with our partners, with PAHO, with USAID, that there were a lot of weaknesses. However, and many of the health workers hadn't been trained in years. However, there were no resources to be able to do in-person trainings. So with this course, we were able to reach to every single level in the country. And we also made sure that the technology was extremely simple, that you could actually do the course on a simple telephone, because the majority of the health workers don't even have a computer. So it was like kind of, we were trying to decide how complex should the course be. And at the end of the day, we always went for the most simple model that would allow us to really reach the farthest points with all the health workers in the country. Thank you.
Thank you, Cecilia. And the same question for Dr. Sanjay.
Okay, I would like to highlight two advantages of our online training program. One, as I mentioned, it is very easy for us to quickly inform a huge number of health workers over a short period of time. If there are any changes in guidelines, standard operating procedures, new way of doing business, some new vaccines have come in, it becomes very easy for us because it's a large country and reaching out to far-flung areas could take a lot of time, and there could be a lot of attrition of communication messages. So with this, we are able to sort of fan out, give consistent messages to a huge number of health workers over a short period of time. That is one advantage. The second one I wanted to highlight is that each health worker has a unique ID. So we are able to figure out that which health worker has passed out with good marks in which technical area and where he or she would need further reinforcement. Therefore the supervisor are able to get a handle on the health workers on who is good in what and which one needs further strengthening. So we are able to track individual trainees, and it helps them to do little more sort of tailoring approaches. Previously in uh, instructor led, we did not know who was good, who was bad, how many times a person has been trained, some were left out just like that without any training, because it's a huge number. So this unique ID tells us we have a control on them much better. Thank you.
Thank you, Dr. Sanjay. Now we want to ask them about what pitfall or challenge they had during their online approach. So we'll start with Jhilmil.
Yeah, it was a challenge for us to have a gender balance. So we had less than 20% women um, enrolled and then completing the fellowships. So it relates to the discussion that we had this morning and the comment a colleague made about women accessing digital tools. So, although we tried a few mechanisms, we tried to reach women candidates with targeted messages and provide them support, specific support during the sessions, but we are far from achieving that balance. But we are really committed to seeing a greater number of women participate and complete these fellowships, because capacity building does link to career development and ultimately to women empowerment. So we're very keen to really understand, why are women not participating? Does it have to do with the format of our online offering, or does it have to do with our selection criteria? We did have a selection criteria. Was it doing something against getting the right women in? Or is it really social and cultural barriers, but there might be certain things that we could include in our programming, we could change in our programming so that we are more supportive of those women. And so we are, like, in the future rounds, very keen to really find answers to this challenge.
Thank you very much. And the same question for Vivian. Oh, Cecilia, sorry.
Well, thank you very much. Yeah, for us, I think it was actually the time it really took to get this course online and ready to be implemented. So actually, with the in-person training, we just had it already prepared, and we just needed the funds, right? But for the online course, we needed to follow a lot of steps. First of all, it took us several months, and our regional colleagues were really helpful on that, on trying to decide what the best platform was. So there was a lot of discussion. And then second, within the government of Guatemala, there are a lot of requirements for trainings that are going to be online, but are approved by the government. So all those requirements were not as easy as we thought, and we had the pressure of COVID, Yeah, we were right now. I mean, it was the time where we were starting the entire COVID-19 vaccination program. There were a lot of needs at the ground. We needed to really get there, but this process was taking a long time. So I would say that was our test for patients, although we knew that in the end it was going to prove very valuable. It took longer than expected. And then also, of course, the validation process, ensuring that a group of staff of workers could actually do the training, get back to us, and give us all the feedback. So at the end of the day, yeah, it took longer than expected, even if it was worth it. Thank you.
Thank you very much for that. And Dr. Sanjay, what was a pitfall or challenge with your approach?
We had few challenges. One was already spoken about, the time for initial setup. It took time so to set up the initial platform. What was the best platform? What were the features of that platform? What are the enhancement features? Where will it be hosted? So it took initially little time. But the two other challenges which we faced was that India is a big country and health is a state subject. And each state, can independently take health-related decisions, and therefore the offtake or the uptake of this RISE platform was fast in some states and slower in some states. And the reasons can be many. There could be political reasons, or the local decision makers have many other multiple priorities, and they would not allow the health workers to take this training course quickly. So there were multiple factors. What I want to say is that the pace was uneven. And finally, the third issue which we face is a language issue. We have so many languages, and these are interactive modules. It's a very interesting module. I can't do a demonstration, but otherwise, if you see it, it's very interactive. It takes a lot of effort to convert it into different languages, because everything has to be moved and done separately. And with the variety of languages we have, it takes time to sort of convert those. So these are some of the challenges.
Thank you so much for that. And our last question is, overall, what was something you were proud to achieve with this training? And we'll start with Elizabeth.
Great, thank you. So we did a process evaluation at the conclusion of the initial fellowship cohort. And it was really notable from the surveys and interviews that we conducted, just how much the impact the fellowship had on all participants of the program. So our fellows, our mentors, and even the organizing staff. So in terms of the fellows, we had nearly all 30 individuals who continued on to phase 2, so the mentorship and implementation phase of the fellowship, who were able to either fully implement their project or prepare their case study for publication. In fact, we recently published several case studies and stories on Boost Bright Spots website that document both the successes and the challenges that fellows face during the course of implementing their projects. And considering the short timeline of the fellowship, which was 6 months for implementation, we were really excited just to see such promising results. We also received positive feedback from mentors, some of whom learned just as much from their fellows during ongoing one-on-one interaction with them. So, for example, one mentor who works at the global level gained new insights into challenges faced by some of our mentees who are working at the subnational level of the immunization system. And we felt this continuous two-way learning really allows for greater growth all around. And as a result of that initial impact, Sabin and WHO launched actually a second cohort this year, which we're currently midway through. And if you want to learn more, I'm actually hosting an innovation cafe tomorrow morning and have some of those stories from the fellows. So feel free to stop by. Thank you.
Thank you, Elizabeth. And the same question for Vivian.
Thank you. So we're really proud of course, the online training per se, but of course, the sustainability. It's sitting with the Ministry of Health. They will be able to actually just continue to use it, to adapt it to what they wanted. It's also open not only to the Ministry of Health, but to the Social Security, which is one part that we that coordination wasn't great at the beginning, and now they're coordinating greatly, and they are using like the same tool to knowledge. then the eager that we found from the health workers, that at the first cohort last year was 200 health workers. Now this cohort is 800, and they can continue to grow, and they really like it. What we have like as a feedback from the Department of Capacity Building of the Ministry of Health is one of the most popular that they got, because we didn't have that training in person or before COVID. So it's something that it's continued to grow. And also that what we are really proud of is the coordination. As you know, it's not only during COVID, but it's always that we as stakeholders keep like knocking doors at the Ministry of Health, and sometimes it's the same topic that we're eager to coordinate, or to help, but the coordination isn't great. We were talking about just working with and coordinating with 4 different departments in the Ministry of Health: immunization program, logistical unit, the capacity building department, 2 vice ministers, and all of them were okay with coordinating together. Then with Bajo Guatemala, Bajo Regional, UNICEF Guatemala, UNICEF Lacro, which I know it's just, oh, they are helping, but just getting all these people together and just saying, oh, we agree to do this, that was really awesome. Coordination takes time, as Cecilia mentioned, but it was really worth it at the end what we reached. Thank you.
Thank you, Vivian. And Dr. Sanjay, something that you were proud to achieve with your online training?
2 things. One, the first thing is that the government of India owns it and has committed that it would expand it at its own cost. It was initially funded by Gavi for the first couple of years as a pilot, but now they have sort of made sure that they would in the forthcoming years expand it to the whole country at their own domestic cost. That's one thing which we are very proud of. The second thing is that this has given more power to the health workers who were not very strong. We have 250,000, most of them are women vaccinators, and not each one of them is very active or bold to get trained or ask for trainings. This gives particularly amongst the health worker cadre, the women who are less sort of dominating and less vocal, it gives them power to also get trained. So it kind of it makes it little more equitable than it was previously. So that's also what makes us proud. Thank you.
Thank you so much. And so that was our last question. We wanted to leave enough time for everybody else here in the audience to also raise some questions. But I'll start. I was very intrigued that for Jhilmil's intervention, that there was that gender disparity in terms of enrollment. And so I wanted to ask you what you thought might be the reason, if you were able to figure out what might be behind that imbalance. And then after that, ask the rest of the speakers if they saw any gender differences as well in their programs.
Yeah, so that's a very good question, Manjari. So I mentioned that we had a selection mechanism, and first we were looking to take people out because there were just too many, and we wanted to see target it much better. So we had a few criteria, and one of the criteria was describe what you do. And what we realized was that women candidates were much more modest about what they do than their male counterparts. And so the reason to include a male participant was higher than based on just looking at what they do, was higher for the male candidates than female candidates, because they were very modest and like saying exactly what they mean, and like even for internet connectivity or there was a question on do you have approval of your supervisor, and if it's a yes, then you are more likely to be in. And so women candidates were very upfront if they didn't have a approval from their supervisor. So those were some things that we felt like were taking women candidates out of the pool. And so then we started to look for reasons to include rather than reasons to exclude, especially for the women candidates. Yeah.
Thank you, Jhilmil. And Vivian?
Okay, so from us, it was a shift when all the course was in person. more male were participating instead of women. When we changed it to online training, now we have 25% of male population on the training and 75% of female. And one of the things that we have been like talking with the Ministry of Health and what that shift mentioned is, first of all, because it was in-person training when we were in the middle of pandemic, a lot of the males were the ones who actually wanted to participate. So when we sent out the invitation, they were the ones who didn't have to take care of their family, their babies, and that's why they wanted to leave and could leave for 3 days. But now that it's online, and we have a really strong vice minister that is pushing for the training also. She's also eager to ask them to just prioritize everybody that wants to take the training, and that's what even they are asking them if they don't have at home, because they can take it at any time. Internet, they could do it during some hours of work, because it's something for their knowledge and also will help for the ministry. So that's something that's why the shift is there. But we continue to figure out what's else there.
Thank you. And Dr. Sanjay, any comment on that?
Since I noted that most of the vaccinators in India are women, we didn't face that issue per se, and we have not done any implementation research. But very soon we will be also rolling out a modular training for medical officers, where there is probably 50-50 men and women, and it'll be very interesting for us to see, what would be the uptake and things like that. My hunch is that there'll be more reluctance from men. That's what my guess is. More men medical officers will be reluctant to take this training, and they would probably not give that level of importance as compared to women. That's my hunch, but we are yet to find that out. Thank you.
Thank you very much. Any questions from the audience? Could we get the microphone here?
Yeah, thank you so much, panelists, for that insightful presentation. My name is Matiko Machage from Insupply Health, Tanzania. Yeah, I'm interested to learn or to know more about when you are developing these platforms, when you are like doing the user requirements. Were there any behavioral aspects that you learned that you incorporated in the design, or even during the implementation? Have you learned any behavioral aspect that either motivates users to take these online trainings or prevent them? Because I know like one of the challenges sometimes is the uptake, and you might have everything good, but probably the behavioral aspects affects that or influence that. I would like to learn more about that. Thanks.
Who wants to take that question? Vivian, go ahead.
So first of all, one of the things that we started like we did the assessment was what the Ministry of Health was using. So of course, like even if we did different assessment, we actually prioritized what they were using. So if we wanted for it to be sustainable and to be sitting in the Ministry of Health. The other thing that we ask is and that's why we work with the capacity building department of the Ministry of Health, what was that actually make the health workers wanted to take a training. And it's not only knowledge, but also at least to have a certification. That's something that at the end is what they want, at least to have the diploma. And that's something that we work with the Ministry of Health, also PAHO and UNICEF. So at the end of the training, they will have the certification, and it will be signed by the three of us. So that's something that they like, and that's why even, well, of course, the training per se is fun. It has to be, because if not, it's a lot of hours that they have to be there, and just it's long. But just to have that certification is really valid for them.
Dr. Sanjay, I think you also wanted to
So,
comment.
if I understood the question correctly, when we did that capacity assessment, we did a sort of behavioral assessment also of what their behaviors are, their knowledge are, their attitudes are, attributes are related to immunization of children and pregnant women. So that also fed into the design of that learning management system. One motivation which they have is this certification. So if you get X percentage marks, you get a silver certificate. If you score higher, you get gold, you get platinum. So there's a healthy competition amongst them, that who gets silver, who gets gold, and who gets platinum. So if a person has gotten silver today, the person can take the training again and get better, gold or a platinum. The second motivation is that there is a possibility, I'm just saying a possibility, that the government of India may allot some credit systems to this, so that once you get into a number of credits, they may get some, benefits in promotion or probably for, upgradation. So that is also in the works. It's not yet been formalized, but that's what is being thought about.
Thank you very much. We have another question here. Who has the microphone?
I,
okay.
I am Sri Hari. I am from UNICEF Regional Office of Middle East and North African country. I'm health specialist there for EPI and primary healthcare. COVID has taught us how to best utilize the digital platform for many purposes, including the training. So there are many advantages. My question is related to skill development. So the online training definitely good for knowledge enhancement, but in terms of the skill enhancement, means knowledge and some of the means in case of immunization, except the vaccination or vaccinator, how to give the vaccine, other component can be very well managed. But in terms of skill enhancement, performance enhancement, I think that there has to be the technology or platform that need to be used, need to be differentiated from the knowledge enhancement, and how we are ensuring that the skill and knowledge that has been given is utilized and performance has improved. So what mechanism we are trying to put in place to do that? So is there any studies, assessment, research that has been done that by this knowledge, by giving this knowledge through this online training, this has happened? So is there a continuous prospective study done any place? It would be good to know that. Thank you.
Who would like to take that one? Cecilia?
I will start, but I don't have an answer for you on the study. Just to mention maybe our experience in Guatemala, and then maybe someone even in the public has an experience on a study. For us, we have tried to do several online courses during the last 10, 15 years. And a couple of them, and I'm thinking right now one specifically on breastfeeding, we realized that we just couldn't do everything online. There was a very practical, how do you, like you had to test exactly how we are supporting mothers to really feed the baby, etc. So with the government, with the Ministry of Health, we decided to have a theoretic part and then a practical. Yeah, so it was a number, like it was 22 hours of a course that is like theoretical and virtual, and then we have the practical side. However, it has also disadvantages, because at the end of the day, there are always issues to be able to implement the practical side, especially if you are working in a context of limited resources. Sometimes we're just waiting for the government to be able to, just make sure that they have enough resources to implement that practical side. And sometimes we just have too many workers in the country interested, and we have a waiting list that is too long. So they are not able to get certified just because of that practical side. Yeah. So I think it has pros and cons, but definitely for that course, we felt that it was necessary to have that practical side. Now, for the study, I don't know whether anyone has.
Jhilmil?
Yeah, so there is going to be in the plenary, I have a presentation on this systematic review, which was done for effective training strategies. So there are some studies. Basically, what they found out from the systematic review was that anything alone does not have that much effect. Particularly, if you say, well, now that we've developed the online course, everything is taken care. You're very right. Skills development needs follow up, somebody watching over, correcting. So maybe the solution is to couple the online training with some sort of mentoring and supportive supervision, and not just leave it for health workers to just learn from the screen.
Yeah, I would like to complement that precisely that let's remember that training is never a standalone approach, right? We always need to also conduct supervision for any of our programs. So that will make sure that we are seeing the results of training, right? And where things need to be strengthened for training, independent of any implementation research that we might be doing. And then precisely what they were talking about, that component is what we call blended modality, right? Like you can do self-paced modules, right, that will deliver the basic knowledge, and then you might have a virtual session, live session, and maybe you gave them homework, right? Like go and practice this in real life and then come back and share your experiences. So that would be a blended modality. So there's several options really to address that very important aspect of skills. One more question. Sorry, she had the microphone first. Oh, you have the microphone, but then I saw her with the hand before, so let's after your question, let's give
Okay,
her. Yeah,
thank you. But I was told that I have the last question, therefore they gave me the mic.
Okay.
But in any case, thank you so much. Now, my question is perspective, looking into a futuristic part, and this is for all the panel members. The need for online training is well established. The BC time, before COVID time, and the after COVID time has very clearly demonstrated that this becomes a component and not just the sole part of training. Is any of those modules that we are talking about, any of these platforms that we are talking about, if a country wants to adopt that, are any of these platforms built on open access platforms? Can a country take because the content will be based on country's program and the design, but are these structures available online, or are these structures available which a country wants to adapt, can take it from this, or are these based on closed platform? How do we take from one country to another rather than some other, again, starting developing it from the scratch? So just to want to ask on that.
Dr. Sanjay?
So at least for India, I can tell that it was the first requirement of the government of India that whatever platform we develop should be an open source platform. So it's available and it's an open source, and anyone can sort of accept it, modify it the way you want it.
Thank you. And we do have time for one more quick question.
Thank you very much. Thank you. I have
Yes.
the microphone.
Yes.
Thank you. Dorothy Lee from. Okay. So, may I?
Yes, please go ahead.
Thank you very much. Dorothy Lee from Ganeshade. So this is a question to you regarding the measurement of the impact or outcome of online training. We are very focused most of the time on the knowledge gain. Then what about the measurement of the transfer of knowledge into concrete application and so on? Is there any protocol, or how do you make sure that the online training will impact, not impact because it's a little complex, but at least increase the skills and the performance of the human resources for health?
Cecilia?
So at least for what we have done is because we started training with in-person training. So we have champions in every region of the country that already took the course in person, and they know how to apply it, and they know, like, they have the skills. And as you mentioned, we know we could see the skills. So we have the mentors on the course and also the champions of every region, so they can actually see what they are implementing, what they have learned. And also if they have questions, they can go to them. And that's something that we make sure to give them, like the list of champions for every region, so they can get there and they also go and monitor what they are doing. That's how we follow that up.
Thank you very much. Cecilia?
Yeah, sometimes also what we have tried is to have evaluators, but I mean, if you have too many people doing the course, just doing some random sampling to be able to ensure that, okay, you are making sure that, at the end of the day, you get some information back so that you can, whether you have to improve something or not. So we have done that with some courses.
Yeah, in our design, we had inbuilt this strategic proposal component. So people attend the live engagements, and then they have to contextualize it and prepare a proposal, which then also follows through with implementation of that proposal. So the fellowship covers the whole cycle, and that's how we know that they have kind of used it in their context. But it's a very good question.
We have 3 minutes left if you want to ask your question. Yes, right here, because they already took it away. Oh, over there, yes,
Well,
because
okay,
they
so let's
took it away.
let's go. I think a part of it was related to the quality of, let's say, the online training, and I was wondering if you had the chance to compare basically what has been done online with what we were doing in the past. That's probably one quick question. One comment, very quick, is please remind us that for the last 30 plus years, we have been also doing physical training, sometime to incentivizing people. So one of my concern today is that with online, and very often, let's not forget that mobile phones and all that cost money also. So I would like to make a quick, let's say, analysis, economic analysis on that, what they are losing and what they can gain in doing things online. So that's one quick comment. So, and to me, we have, let's say, in the strategic document to be really clear on what we are going to put online and what should remain more traditional. Thank you.
Thank you very much. Let's give a round of applause to all our speakers, and thank you everybody for coming to the session.